Now over here it is a clear cut, morphologically clear cut. You can see the acinar pattern of adenocarcinoma. So there is no problem whatsoever in this biopsy. The tumor is consisting of an acinar arrangement of the gland with epithelial cells lining the luminal space. So this is an adenocarcinoma acinar. So this is the nuclear positivity of the TTF1 as we can appreciate. Okay. So but once if you are requiring the IHC, okay, then you will give the diagnosis as non-small cell carcinoma favors adenocarcinoma, and then you give TTF1 positivity result. Now over here, as you can clearly see, okay, the keratin pearls over here. So you can classically see the keratin pearls. So this you can straightaway write as squamous cell carcinoma. The tumor is showing nest of malignant cells with focal keratinization. There is nuclear enlargement, hyperchromatic nuclear chromatin as we can see, and the prominent nucleoli. Okay, myself Dr. Jibran Ahmed presents to you Simply Pathology, and we are back with another very important video. Here we are going to discuss about the guidelines for good practice of small biopsies and cytological preparations of the lungs. So WHO has given a clear-cut guideline of how to report the small lung biopsies as well as how to report the lung cytological slides. So for small biopsies and cytology, non-small cell carcinoma should be further classified into a more specific type like adenocarcinoma or squamous cell carcinoma whenever it is possible. So it's very important. So what used to happen previously any kind of lung tumor, okay, they used to be diagnosed under two headings, either small cell lung carcinoma or non-small cell lung carcinoma. So these were the two headings. So under the non-small cell lung carcinoma, we are having adenocarcinoma and we are having squamous cell carcinoma and other carcinomas like large cell neuroendocrine tumors or large cell carcinomas like that. So what the WHO is saying, the WHO is saying that we should not use this term. Okay, we should be specific. We should try as much as possible morphologically and immunohistochemically to either give a diagnosis of adenocarcinoma or squamous cell carcinoma, okay, in the small biopsy or in the cytological smears. Along with that, if small cell carcinoma is very clear, then we can directly give the carcinoma as small cell lung carcinoma. But we should avoid using the term non-small cell lung carcinoma. This is very important to understand. Second important thing, the term non-small cell lung carcinoma NOS should be used as little as possible. Now, non-small cell lung carcinoma NOS means when you have exhausted all the possibilities, when you are sure it is not an adenocarcinoma, it is not a squamous cell carcinoma, it is not a large cell carcinoma or large cell neuroendocrine tumor. So when you have exhausted all these things, okay, when a specific diagnosis is not possible, then you are using the term non-small cell lung carcinoma NOS. But this use should be done after you have exhausted everything. Okay, after you have exhausted morphological evaluation, immunohistochemical evaluation, so after molecular evaluation, after everything, if you cannot get an answer, after that you can give this term non-small cell lung carcinoma NOS, but not to be used very frequently. When a diagnosis is made in a small biopsy or cytology specimen in conjunction with special studies, it should be clarified whether the diagnosis was established on the basis of light microscopy alone or whether any special stains were used. So if you have used any special stain, if you have done any special study, then you should always mention that you have done this study and this was the result, and after that you are giving a diagnosis. Now the term non-squamous cell carcinoma, sometimes what happens that you rule out that it is not a squamous cell carcinoma. It is a large carcinoma, but it is not a squamous cell carcinoma, and you use the term non-squamous cell carcinoma. That should not be used. Now the classification of adenocarcinoma that we have seen, okay, whatever classification that we have seen in the 5th edition of the WHO, it should be used in routine diagnosis, okay, and very importantly, whenever you are using this classification, so whenever you are reporting, you should always report on the basis of the WHO 5th edition. So whatever classification of adenocarcinoma is given along with the types and pattern, that only should be used while you are reporting these specimens, so as to ensure uniformity. Now, when you are pairing the cytology and biopsy specimen together, then both of them should be reviewed together to achieve the most specific and concordant diagnosis. The terms adenocarcinoma in situ, remember the term adenocarcinoma in situ as well as the term minimally invasive adenocarcinoma cannot be used while reporting small biopsies or cytology specimen. Very, very important. Okay, if a non-invasive pattern is present in a biopsy, it should be referred to as a lipidic growth pattern. So you cannot rule out invasion from a biopsy, okay, or from cytology. So always you should mention, instead, if you are thinking that it is a non-invasive pattern, then use the term lipidic instead. Okay, this is very important. The term large cell carcinoma again cannot be used in a small biopsy or cytology specimen. Okay, again very important, they cannot be used. Okay, and it should be restricted to resection specimen. So the diagnosis of large cell carcinoma can only be made on a resection specimen and not on a small biopsy or cytology smear. Okay. In biopsies of tumors that show sarcomatoid features, that means there is marked pleomorphisms or presence of giant cells or spindle cell morphology. So this should initially be classified as above, means you ought to write adenocarcinoma or non-small cell carcinoma favoring adenocarcinoma, or squamous cell carcinoma or non-small cell carcinoma favoring squamous cell carcinoma. So whatever points or whatever terminologies that you are using, you should use. But along with that, you should just give a comment that along with this, sarcomatoid features are also present. Okay, so this is how you should report. But the term sarcomatoid carcinoma cannot be used toto as a diagnosis in a biopsy. Okay, this is very, very important. In a biopsy or in a, so it has to be again confirmed in a resection specimen. Now, staining for neuroendocrine IHC markers should be performed only in cases when you are suspecting neuroendocrine morphology. Okay, it should not be a routine panel in the IHC. In the IHC, initially you have to give the markers to rule out adenocarcinoma or squamous cell carcinoma like TTF, napsin, P40, P63. Okay, but routinely neuroendocrine markers are not to be included. So, what are the 4 things that cannot be confirmed on a small biopsy or a cytology and has to be confirmed on resection? Adenocarcinoma in situ, minimally invasive adenocarcinoma, large cell carcinoma, and sarcomatoid or pleomorphic lung carcinoma. Okay, so these cannot be confirmed directly on resection, and the diagnosis should only be made on a resection specimen. Also, one more thing, whenever you are reporting an adenosquamous carcinoma, you cannot report it just on the basis of small biopsy or cytological preparation, because at least 10% of each has to be taken. Okay, so with this we have completed the guidelines for practice on small biopsies and cytological specimen. Now, very importantly, we have to understand what are the terminologies that has to be used, okay, in a biopsy and cytology versus the resection specimen. Okay, so what terminology you will use in biopsy and cytology versus the resection specimen. Okay. So the reports, so first very important thing, the reports of lung cancer diagnosis based on small biopsies and cytologies need to include the following. So the diagnosis has to be in concordance with the 2021 WHO classification of lung tumors, number 1. Number 2, you should also mention the result of the immunohistochemical or mucin stains. Any special stain that you are doing should always be mentioned. A comment about the differential diagnosis when appropriate has to be given. A statement of whether any material has been submitted for molecular testing and if the results were available. As already mentioned, the term non-small cell carcinoma NOS should be used as less as possible, because we want a more specific diagnosis so that the patient can get a treatment out of it, either based on morphology or special staining like IHC or mucin stain. Now, in some cases, when poorly differentiated carcinomas are encountered without any block or unstained slides to pursue a further workup, a diagnosis of non-small cell carcinoma or NOS can be made. However, it should be, clearly mentioned why you are using, because material wasn't available for further workup. The term large cell carcinoma should not be applied on a small biopsy or cytology specimen, as I have already said, because this is a diagnosis of exclusion and you can only exclude after you have screened the entire resection specimen. Okay, so this can only be made on a resection specimen. Again, the diagnosis adenosquamous carcinoma cannot be made on the small biopsy and cytology because it requires a resection specimen with more than equal to 10% of each component. In such cases, the recommended diagnosis is non-small cell carcinoma NOS with a comment that both adenocarcinoma and squamous differentiation component is present, and it raises that a consideration of adenosquamous carcinoma can be made after the sample has been resected, but the diagnosis cannot be made on small biopsies or cytology. Again, pleomorphic carcinoma, that is the one having sarcomatoid features or sarcomatoid carcinoma, again cannot be diagnosed on the basis of small biopsy or cytology specimen because it requires a resection specimen showing more than equal to 10% of spindle and or giant cell component. If a pure lipidic pattern is seen in small biopsy, if we are looking at a pure lipidic pattern, okay, in a small biopsy, the differential diagnosis includes adenocarcinoma in situ, minimally invasive adenocarcinoma, or invasive adenocarcinoma with lipidic component. So over here, we cannot be sure about the invasion, and for the diagnosis or to rule out invasion, we have to have a resection specimen. Again, these diagnoses, they cannot be made in a cytology smear or in a small biopsy. They require a resection specimen. So these are the terminologies that we are going to use. So when you are sure in a small biopsy and cytology, so on the left hand side we have the terminologies for the small biopsy and cytology, and on the right hand side we have the resection specimen. So very importantly, if you are sure morphologically about squamous cell, you can give the diagnosis straight away in the cytology smear. Then in resection specimen, again the same term is used. Again, if you are sure of adenocarcinoma, so about adenocarcinoma patterns, you have to write the adenocarcinoma. If you are morphologically sure it is adenocarcinoma, along with that you have to state the patterns. Okay. Now again on the resection specimen is the same thing. Very important, the terms minimally invasive adenocarcinoma, adenocarcinoma in situ, and adenocarcinoma with a lipidic component, that is the invasive variety, they can be used in resection specimen only. But if you are thinking about these three things in a small biopsy or cytology, the term adenocarcinoma with a lipidic pattern has to be used instead. This is what you will use in a small biopsy or a cytology specimen. Now, invasive mucinous adenocarcinoma, again just like the non-mucinous varieties, if you are getting mucinous component, you can straight away give the diagnosis of invasive mucinous adenocarcinoma. You can state the pattern as well. Okay. If the pure lipidic pattern is there, then you should mention the differential diagnosis as on the right hand side. Okay. So again over here, if it is invasive mucinous, you can straight away write, like in the resection also it is the same. But if you are thinking minimally invasive adenocarcinoma in situ mucinous variety, then this diagnosis has to be made only on the resection. Okay, only on the resection. If it is done on a small biopsy, then you have to write lipidic pattern, and in the differentials you can write them. Then adenocarcinoma with colloid features, they are stated as colloid adenocarcinoma. Fetal features, fetal adenocarcinoma. Enteric features, enteric adenocarcinoma on the resection specimen. Now, morphologically, squamous cell patterns, if they are not present, but they are supported by IHC, you are seeing that P40 is positive or P63 is positive. So, over here you will state non-small cell carcinoma favors squamous cell carcinoma. The term favors squamous cell is only when morphologically you are not sure, and by IHC it is sure. Again, on the resection it is squamous cell carcinoma. Non-keratinizing pattern may be component of the tumor. You have to state like this. Again, morphological adenocarcinoma patterns not present but supported by special stain, that is TTF1 IHC positive or napsin A positive is there. Then you give the non-small cell carcinoma favors adenocarcinoma. Adenocarcinoma solid pattern may be just one component of the tumor. Again over here, again adenocarcinoma. So remember over here. So when you are not sure of by morphology, then you carry out IHC, and in IHC if you are getting the markers for squamous cell, then non-small cell carcinoma favors squamous cell carcinoma. Again for adenocarcinoma, non-small cell carcinoma favors adenocarcinoma. Now no clear adenocarcinoma, squamous or neuroendocrine morphology or the staining pattern. So if you are not sure morphologically, if you do not have access to the IHC pattern, then you are going to use the term non-small cell carcinoma NOS, not otherwise specified. Okay, and the same thing, that actually this is a diagnosis of exclusion. So non-small cell carcinoma NOS is when either morphologically and by IHC you cannot reach a diagnosis, or morphologically you are not getting a diagnosis and you do not have access to IHC. Then you are going to take the diagnosis of non-small cell NOS. Now the same thing, if you are getting a resection specimen and again you are not sure what is the tumor, what is the type, it is not a small cell, it is not a large cell neuroendocrine, it is not a adenocarcinoma, it is not a squamous cell, then by exclusion it is a large cell carcinoma. So this can only be made on a resection. I hope this is very crystal clear to everyone. Okay. Now for small cell carcinoma, again the same terminology is on the biopsy as well as resection. Non-small cell carcinoma with neuroendocrine morphology and positive neuroendocrine markers, possible large cell neuroendocrine carcinoma. Okay, so this is what you will use in small biopsy, and on resection directly large cell neuroendocrine carcinoma. Morphological squamous cell and adenocarcinoma patterns present. So in that case you will give non-small cell carcinoma NOS with a comment that adenocarcinoma and squamous components are there, but the diagnosis will be non-small cell carcinoma NOS, and the diagnosis of adenosquamous carcinoma, if each is present, each is constituting more than 10% of the entire tumor, then the diagnosis will be made on a resection specimen only. Morphological squamous cell or adenocarcinoma patterns are not present, but IHC favors separate squamous and adenocarcinoma component. Again you will give non-small cell carcinoma NOS. Okay, specify the results of the IHC stain and the interpretation and the comment that this could represent an adenosquamous carcinoma, but diagnosis will require a resection specimen. So again over here on the resection specimen you will give adenocarcinoma, squamous cell carcinoma, adenosquamous carcinoma or large cell carcinoma with unclear IHC features. So when both the patterns are not present and IHC is favoring separate squamous or adenocarcinoma component, in that case on the resection specimen also if you see, then the diagnosis will be written in this particular manner. Okay, whatever you are getting via the IHC, depending on the IHC. If you are getting only adeno, so you give adenocarcinoma. If you are getting only squamous, then give squamous. If you are getting both, then adenosquamous. If both of them are absent, unclear IHC, then you will give large cell carcinoma. Non-small cell carcinoma with spindle cell or giant cell carcinoma, if it is there. So when you are finding such tumors, again you will use the term, whether it is adenocarcinoma, whether it is squamous cell carcinoma, whatever it is, you will see adenocarcinoma or squamous cell carcinoma. Along with that, you give a note that we are getting features, we are getting certain sarcomatoid features, certain pleomorphic features. Just give a comment on that. Okay, then definite diagnosis will require resection specimen once again. So on the resection specimen, now you can give it is a pleomorphic or it is a spindle cell or it is a giant cell carcinoma. Okay, so certain diagnosis can be made only on the resection specimen. Okay. Now we are going to see the different histopathological images. Okay, now this is the pattern, this is the biopsy, histopathological lung tumor biopsy we are seeing. So over here, this is the adenocarcinoma lipidic pattern. So we can only see the growth which is limited to the lung alveoli. What we can see that there is widening of the alveoli, little bit fibrosis is there, and there is also there is the atypical growth of the tumor cells, but they are limited to the alveolar spaces. So the tumor is showing preservation of the alveolar architecture as we can appreciate over here. So this is the alveolar wall and in between the alveoli is there as we can appreciate. Okay, with uniform proliferation of crowded atypical pneumocyte. There is mild fibrotic thickening of the alveolar walls as we can appreciate. See the fibrotic thickening over here. So basically the differential diagnosis, it can be minimally invasive. Okay, it can be adenocarcinoma in situ, it can be invasive variety of adenocarcinoma, but the definitive diagnosis can be made only on a resection. You cannot. So for all these three, if you are suspecting either of them, okay, you will write adenocarcinoma lipidic pattern in a small biopsy specimen. Now over here it is a clear cut, morphologically clear cut, you can see the acinar pattern of adenocarcinoma. So there is no problem whatsoever in this biopsy. The tumor is consisting of an acinar arrangement of the gland with epithelial cells lining the luminal space. So this is an adenocarcinoma acinar pattern. Again, this is the next image. Over here you can again see the adenocarcinoma, but the classical papillary pattern is there. Okay, you can see the cut section, they are containing the fibrovascular cores over here. You can see the fibrovascular cores. Okay, this is the adenocarcinoma papillary pattern. The tumor is showing a papillary architecture with fibrovascular cores. Next over here, what you can see, this is an invasive mucinous adenocarcinoma. So you can see in the mucinous variety, you will see the presence of some amount of mucin. Okay, and you see the mucinous cells. So you will see the tall columnar cell with basally located, okay, with basally located nucleus over here. Now over here, we can see the pattern. They are present in both the papillary pattern as well as they are present in the acinar pattern over here. If you look in the high power view over here, we can see the individual tumor cells, and what we can appreciate over here, the cytological features of the tumors, they are containing abundant amount of mucinous cytoplasm. So if you see the tall columnar cells over here, okay, they are filled with mucin over here, okay, and basally located nucleus, okay. If you take over here, if you see over here these tumor cells, see the basally located nucleus and the apical mucin over here, okay. Again over here also you can see the apical mucin and the basally located nucleus. So this is the classical feature of the mucinous variety, okay. This is the classical feature of the mucinous variety of adenocarcinoma. Now the colloid adenocarcinoma, wherein you can see the tumor cells mostly consist of what is called as pools of mucin. We can see pools of mucin are present. Along with that, you can see the pools of mucin, and you can see very scant tumor cells, okay, bland tumor cells you will see. Over here you can appreciate in the high power view, you can see certain signet cells also over here, okay, certain carcinoma cells. So cytologically very bland tumor cells are present in the background of abundant mucin. See, you can see some basophilic mucin material which is kept over here, okay. Now this is the solid pattern of adenocarcinoma, but they are also having a pseudosquamous morphology. So the adenocarcinoma is showing a pure solid pattern with abundant eosinophilic cytoplasm and very sharp intracytoplasmic border. Usually both these features, they are very reminiscent of squamous cell carcinoma. So these are pseudosquamous features. Why we are saying pseudosquamous? Because after this morphology there was a confusion, and after that they had done the immunohistochemistry, wherein they had seen that they were definitely diffusely positive for TTF1. So TTF1 nuclear positivity was there. So that is why the diagnosis of solid adenocarcinoma was given. So this is the nuclear positivity of the TTF1 as we can appreciate, okay. So but once if you are requiring the IHC, okay, then you will give the diagnosis as non-small cell carcinoma favors adenocarcinoma, and then you give TTF1 positivity result. Now over here, as you can clearly see, okay, the keratin pearls over here. So you can classically see the keratin pearls. So this you can straightaway write as squamous cell carcinoma. The tumor is showing nest of malignant cells with focal keratinization. There is nuclear enlargement, hyperchromatic nuclear chromatin as we can see, and the prominent nucleoli. Okay, so this is very much squamous cell carcinoma. Again over here, the non-small cell carcinoma, which is favoring adenocarcinoma. Now over here, basically, we cannot see very well defined growth. Some areas they are showing solid growth pattern, okay. Few areas they are showing a adenoid pattern, but it is not very convincing. So over here again we have to go for the IHC, and over here the IHC was again positive for TTF. So in such cases which requires IHC, the diagnosis will be non-small cell carcinoma favors adenocarcinoma in core biopsy after we have done the IHC. Okay, so this is how you will give the diagnosis. Similarly, over here in this particular one, okay, we are not very sure whether it is a adenocarcinoma or squamous cell carcinoma. So we have done the IHC. In the IHC over here, there was P40 positivity. Okay, so after P40 positivity, then only we can give the diagnosis as non-small cell carcinoma, which favors squamous cell carcinoma. Again, over here, this is the non-small cell carcinoma NOS in supraclavicular lymph node. Now, the tumor consists of pure solid pattern of malignant cells which lacks any kind of glandular or squamous morphology. Okay, even the immunohistochemistry, if you see, they were negative for TTF as well as P40. So, in that particular situation, we have to give the diagnosis as non-small cell carcinoma NOS. Okay, so why morphologically you are not sure, why IHC you are not getting any diagnosis? So basically now you are entitled to use the term non-small cell carcinoma NOS. Now over here, this is basically non-small cell carcinoma NOS, but they are having features of adenocarcinoma and squamous cell differentiation as well. So morphologically you can see certain areas over here, you can appreciate these areas look like squamous cell. See, this area is squamous cell, whereas other areas they are showing certain glands. They are saying glandular appreciation is there, certain gland-like morphology is there in other areas. Okay, certain gland-like morphology is there in some other areas. These are the adenoid areas. These are the squamoid areas. Okay, these are looking like the squamoid areas. So over here, actually, there is a metastasis with both the components. So over here, what we do, we carry the immunohistochemistry. So when we are carrying out a TTF component, you can see the glandular component, they are coming positive for TTF1, nuclear positivity for TTF1 we can appreciate over here. Okay, the adenocarcinoma component is staining positivity for TTF. Okay, whereas over here your squamous cell carcinoma component is again showing P40 positivity. Okay, so those conditions wherein you can appreciate adenosquamous differentiation, and also by IHC you are seeing the similar kind of differentiation. Okay, by IHC also you can prove. So for those cases the diagnosis will be non-small cell carcinoma NOS, and you have to give a comment with adenocarcinoma and squamous cell carcinoma differentiation. With both differentiation we are giving over here. The true diagnosis can only be made on resection. After in the resection specimen we will see that either of the components are constituting at least 10%. Then only the diagnosis will be given. So in the biopsy and cytology we will just use give a comment that adenocarcinoma and squamous cell carcinoma differentiation is also present. That note will be given, but the main diagnosis will be non-small cell carcinoma NOS. So with this, we have completed the complete guide to the diagnosis in lung biopsy and cytology smears. Thank you very much for watching this particular video.